Welcome to this video on hemodynamic impact of ECMO. My name is Kesava Ramakrishnan. I'm a pediatric intensivist. Let us consider VV ECMO first. In VV ECMO, the ECMO flow is returned to the venous side. Therefore, the pump does not have any direct contribution to the cardiac output. In other words, cardiac output in VV ECMO is equal to the cardiac output generated by the heart. However, patients with severe acute respiratory failure are on very high ventilator settings, which may lead to increased intrathoracic pressure and impaired venous return. Also, they may be hypoxemic and acidotic, which may impact on the myocardial function. When the patient goes on VV ECMO, we will be able to reduce the ventilator settings significantly. This may lead to improved venous return, and usually we see an improvement in cardiac output. Correction of acidosis and hypoxemia may improve myocardial dysfunction and lead to a further increase in cardiac output. However, as there is no direct contribution of the ECMO pump to cardiac output, this configuration of ECMO is not suitable for patients with significant myocardial dysfunction. On the other hand, in veno-arterial ECMO, the ECMO flow is returned to the arterial side. Therefore, the cardiac output in veno-arterial ECMO equals ECMO flow plus the native cardiac output. Usually, 60 to 90% of the venous return is sucked out from the right atrium and goes through the ECMO pump to the arterial side. As the ECMO pump provides a significant input to the patient to the overall cardiac output, this configuration of ECMO is suitable for patients with significant myocardial dysfunction. As illustrated in this diagram, the native cardiac output goes down as the ECMO flow is increased, which can be seen on an arterial trace as a decreasing pulsatility. An important aspect to remember about VA ECMO is that it usually leads to a significant increase in the left ventricular afterload. You can imagine the arterial cannula as a hose that is pumping blood into proximal aorta. The heart has to overcome this extra resistance to pump from the left ventricle. Sometimes in patients, the myocardial dysfunction may be so significant that the LV may not be able to overcome this afterload and the aortic valve may not open. If this happened, LV could get distended and the LV EDP and the LA pressure could go up, which may then lead to pulmonary edema. Also, increase in LV EDP may compromise myocardial perfusion and impair myocardial recovery. If this situation develops, LA venting or other strategies to decompress LV should be considered. To summarize, VV ECMO does not have any significant direct effect on hemodynamics. There is no change in RV preload, afterload, LV preload, or afterload. However, there may be an increase in cardiac output due to indirect effects such as reduction in the ventilator pressures and improvement in hypoxemia and acidosis. On the other hand, VA ECMO leads to reduced RV overload, RV afterload, and LV preload, as a significant proportion of venous return will be sucked out from the right atrium into the ECMO pump. However, as the blood is returned to the arterial side, to the proximal aorta, VA ECMO usually leads to an increase in afterload. VA ECMO contributes to cardiac output and can substitute the heart function from partial to complete.